Welcome to the Revita Health and Wellness Show. I'm your host, Francie Marie, and today we're talking about the effects of our testosterone, that hormone, our testosterone, aka the sex hormone. Hello, Dr. Peter Fotinos.
Hey Francine, how are you doing?
Good. The Revita approach, Revita Medical in general, is an amazing practice where if we've got problems in life, aging, even in our teens, you can help us.
Yes.
So let's talk about that sex hormone, testosterone.
And
How is it related to prostate cancer? Because we've been seeing a lot of articles.
yes, so there is this long-term thought that testosterone causes prostate cancer. And it's basically from a not very good study. It was done by a physician in the 1940s, 1941. His name was Dr. Huggins, and he also had another doctor with him, Dr. Hodges. And they administered testosterone to a patient, one patient, and that patient got prostate cancer. And this is where this whole idea that testosterone causes prostate cancer came from.
One patient.
One patient.
Not fair.
Not fair at all.
But it was published, and everybody read it.
Yeah, I read it, and if you go to any physician that is old school, or even some of the new physicians are picking up on this in urology, they'll quote that Huggins study. I don't know about you, but I've been in medical school, did residency. When we looked at studies critically, that's a poor study. That's a case study. That's not a real study. You want randomized controlled trials. You want trials that have more than just one patient. Now, the reason they went this way, and what comes from that is that they think that testosterone is like fuel to a fire for prostate cancer. This is one model.
Okay.
So when you give testosterone, it's going to make things worse. Well, that's unusual because if you look at the studies that have been done on prostate cancer, they've shown that at very low testosterone level, if you have a low testosterone level, usually less than 200, and you give testosterone to that patient, it does increase the risk for prostate cancer up until a certain level, above 200. After that, there's no increased risk in prostate cancer. In fact, recent studies, which I'll go through in a few minutes, show that there's a reduced risk in prostate cancer. So the fuel model, which most physicians follow, is actually one way of looking at it, but it's not the correct way of looking at it. This is what's been taught to us going through medical school and, obviously the Huggins study. But the actual way the prostate works and the way testosterone works to the prostate causing cancer, if not causing cancer, a better way of saying it, is through what they call a saturation model.
Okay.
So think about a sponge. Start pouring water on it. After a while, that sponge gets full and water's just going to fall off of it, right?
Right.
That's the same thing with the prostate. There's going to be a certain point where the receptors on that prostate get saturated with testosterone, and no more testosterone can get on there.
Like an overload.
Yes. So the extra testosterone that's there is not causing that issue with the prostate. So what we found with that, and again, the most recent studies that you're looking at, they're not the best studies, but they've shown that when you give testosterone above those 200 levels, which are less than 200, is considered castration level, basically, that you'll see a regression in prostate cancer, not a worsening in prostate cancer. And the theory behind it is not that testosterone is doing anything with that. It's that because when men have more testosterone, they make more estrogen. And everybody thinks estrogen is bad in men. Not in this case. In fact, estrogen's not really bad in men. There's no natural estrogen blocker in men. So when your testosterone is swimming around 1,000 to 1,200, when you're in your 20s, your estrogen is going to be around 75 to 100. And most people freak out with that estrogen, but if you're not having any side effects with it, which most kids at their 20s are not going to have side effects with that because that's where naturally they are, then we see a protection that occurs from the estrogen. What estrogen has been found to do, and they used to treat prostate cancer with estrogen until they got these LH-RH agonists that what they do is they reduce testosterone to the point that they reduce everything. And they below castration, which they found that when you do that, it does kind of cause the testosterone causes the cancer to reduce when they reduce the testosterone. Okay, So what we found was when your testosterone goes up, you make more estrogen, and estrogen causes prostate cancer cell death
Oh,
and also causes the blood supply to prostate cancer to reduce. And that's why they were using estrogen in the
in the
80s
first place, yeah.
and 90s to treat prostate cancer because it did that. Now these LH-RH agonists, they're called Casodex and Lupron. They do the same thing, but they do it by reducing testosterone to a point where it doesn't feed at a lower level. You know, we said up to 20 or 200, it feeds, right? But the problem with that, when you knock down somebody's testosterone, you're also knocking down their estrogen. And what those drugs were doing were causing men to have osteoporotic fractures, getting depression. They were even getting hot flashes and night sweats. They were going through menopausal symptoms. Men were getting depressed with this. And I've had guys come into me and they say if they had a buddy that started it, and I don't want to deal with it because the guy comes to me, he's depressed. He's about, people were committing suicide on these drugs. And they're still using them because it's a pharmaceutical drug that it's recommended. They tout it's better than what they should be treating, which is estrogen.
So the studies that you actually read, you're able to, and what are the latest studies?
Well, the one that I have, the most recent one, is by Dr. Morgenthaler. Was done in 2011, in February of 2011, and he's done a lot of studies. He is the prostate cancer and testosterone guru. Okay, he's got studies in life extension. Articles in life extension. He's got studies all over the place for this, and he tells you the progression of how it started with Huggins, and then he'll go through and tell you how the evolution of prostate cancer has become. So his most recent study that I have, and I know they're looking at doing probably bigger studies with this, but they have a study. It's not the greatest. It's 12 patients. But think about it. You have prostate cancer, and are you going to enroll in a study they're going to give you testosterone if all you hear is, oh, if you don't take testosterone, it's going to make it worse? No, but these guys volunteered, 12 guys. All of them had what they had. They staged prostate cancer from a scale of 1 to 10. That's called a Gleason score. 10 being worse, 1 being mild. These guys were all of them except for one were 6 and one was a 7. So it was pretty moderate disease.
Right.
They also were symptomatically low testosterone. They were in the 300s. They had symptoms of it. So these guys were given testosterone. I think the average time was 2.5 years. When they first did the study, they did biopsies of their prostates. 100% of them had prostate cancer. Of course, all of them had prostate cancer. At the end of the study, 54% of the biopsies that they did, because they did biopsy every year,
Okay.
54% of the biopsies were negative for prostate cancer. Their testosterone level, I think, was about 600 to 700. So when testosterone makes it worse, when you expect it to make it worse. Now, it's not the greatest study. It's better than one patient,
Exactly.
but it's not the great. And there are other studies. There's several other studies that show that testosterone doesn't, especially if you get it to high levels, it's not going to cause problems with prostate.
Are we going to fund more research? Are we going to have more doctors?
He's going to probably do a larger scale study now based
Okay.
on this.
Which is great.
It's in the pipeline. I know it's going to be more people. They have to do it, and probably going to do a randomized controlled trial on that too.
Well, yeah, what is the ratio of people that they want? What is the percentage of people that makes a good study?
I would say, the more the merrier.
Okay, I say that too,
Yeah,
yeah.
I think I've seen studies with, for example, there was a testosterone and estrogen study in men that was recently done in 2000. It was 400 men.
That's good.
Some of the bigger studies, like the Women's Health Initiative, was 372,000 women. So the more people you have, the more data you have. So.
Right. And we need more data,
Yeah.
more data. But when we come into the office, and when men come into the office and they're depressed, are they gonna go through this process of elimination?
That's
Or
cool.
you're going to do the questionnaire, ask them what's going on, you're gonna do the blood test?
Yeah, we're going to look at that. Currently, I have a couple of patients that have prostate cancer that see me, and we're treating them the way that you should be treated with estrogen and whatnot, and they're doing well. One of them, his physician, who's a urologist, recommended that he don't do any surgery, and he's actually okay with the treatment that we're doing, and the patient's doing great.
That is music to our ears.
So, yeah.
It really is, because my next question to you was, if we do have prostate cancer, is it too late when we come to you?
No. No.
This is great, this is great news.
I'll take anybody with prostate cancer because I know what we needed to do to treat it.
Because it's a brutal way that they're treating it you know.
Yeah, that drug, those drugs, and not to knock the pharmaceutical companies, they've done really good drugs but their cancer drugs have missed the point. One of the big sayings in this medicine is, especially related to cancer, we cured the cancer, but the patient died. We cured the cancer, but the patient's quality of life is crap. You know, why? You know, we get focused on curing that cancer. You know, and I understand cancer. When we hear the cancer word, it's bad. You know, people freak out. But if you're going to destroy your quality of life, and I hear this day in and day out with patients that have had cancer, they see how their parents had cancer. They go through this treatment, and they say, okay, you know, I'm going to go gung-ho at the beginning, and then all of a sudden, the drugs that they're on, the chemo, the radiation, their bodies break down. And I've had patients say, no, I don't care if there's even a 20 or 30% chance of curing. I don't want to do this. Well, this stuff is killing me. You know. And,
quality of life.
Yeah, it's quality of life. You know, if we can find alternative ways, like for example, treating men with estrogen, which we've done in the past for prostate cancer, especially it's metastatic prostate cancer is what you use estrogen for in that situation, meaning it's throughout the whole body instead of just in the capsule, because you don't need to do that as long as it's in the capsule. When you treat them with estrogen, and it's going to improve their quality of life because they're going to reduce the risk for osteoporosis, and they're not going to get hot flashes and night sweats because you're not reducing their testosterone and estrogen, then we should do it, because it's also going to kill those cancer cells. It's going to reduce the burden of cancer cells. It's going to reduce the blood supply to cancer cells. So it's unusual to sit there and say, hey, we only can do these medications. This is the only way you should do it. This is it. This is the standard of care. And this is all we do, because some company said that their drug is better than a traditional way, or not even the traditional way. This has been used before, and so we throw it out because we have these other drugs. It doesn't make any sense.
Well, all we want is doctors to sit down and talk to us anyway. That's one study that I read, is that we just want you to listen to us, look into our eyes, you know, don't tell us, you know, we're beautiful, but just tell us that, you know what, whatever you're feeling right now, I think we can I'm not going to say cure it.
No,
you're right.
we can help.
it.
Yeah, we can help. I mean, you know, the cancer doesn't necessarily have to mean a death sentence.
Thank you.
Okay, there's cancers out there where people they can live for a long time with. You know, there are cancers out there that are very devastating. You know, I'm not minimizing those cancers. Those cancers, there are some cancers that, you know, conventional medicine is right on. You know, colon cancer is one. You know, they're right on.
Pancreatic cancer another?
Pancreatic cancer is one that it's very hard to cure.
Yeah.
You know, ovarian cancer. Ovarian cancer is very difficult. Most people don't present till after it's in stage 4, and that's when we catch most people with that. You know, so what do? Are you going to sit around if your family history has ovarian cancer? You're going to just sit there and look and see, oh, we might have to take the ovary, or can we treat them with something beforehand? A better word is give them something and prevent the disease, or reduce the risk. You can't really prevent 100%, but if I can reduce your risk from, let's say, 50% to 25%, that's significant.
Right.
We still need to look and make sure you don't get it, but that's a big difference, you know. So I've read a recent article in the Charlotte Observer about, you know, and I've had patients come up to me and their doctor says the same thing, is that why are we putting this fear in people about these diseases that can happen, and so we're treating these people beforehand. No, what we're doing is, we're not like a car where we can change our engine out or our transmission, or if something breaks down in you, for the most part, you can't change the part out. And then you don't really want to go through a heart transplant, because they save lives, but they're very devastating. But to sit there and say, hey, if I can catch this disorder before it ever happens and prevent it from happening, or reducing the likelihood that it's going to happen, or I wait until you get sick and fix it, what are you going to do? You know, this should be complementary to traditional medicine instead of being contrary. It doesn't make any sense. I understand why why we act the way we do as physicians, because I'm a family practitioner by training. I used to practice this traditional medicine, family practice. It's the way we're taught, and this is it, and this is it. And we put these blinders on, and it's this way or the highway, you know. Only recently have I noticed some physicians that I've talked to, which is cool, I like this, that are more open to, hey, yes, I've tried this and this, I can't help this patient, what can you do for them? And we use evidence-based medicine. We look at the studies. The studies will lead you this way. you
And
know?
there's thick papers there.
Yeah.
There's lots of studies out there. We just have to open our eyes and read it.
Yes.
And taking the proactive approach that Revita does,
Yes.
Revita Medical, that's the way medicine should be.
Yeah.
And if your father has prostate cancer, then the son can come in and talk to you.
Yes. And we can see, hey, assess your risk, What's going on? What have you noticed? There's signs. There's always a test we can do to look at it. We can look at a PSA. We can do other things, We can follow somebody. I do have that same scenario with that same gentleman. His son comes and sees me, and we do look at his, we follow him on his prostate. And he's doing great. He's on the program as well. And he's happy as heck.
The Revita approach, we like that.
Yep.
Anything else we can leave on when testosterone is involved, the hormone testosterone, and prostate cancer before we leave out today?
I think I've talked about all I think I need to talk about it, but I will tell you this. Prostate cancer is not necessarily a death sentence if you get diagnosed with it. Okay. There again, I have people that have chosen to live with it, and you just monitor it. Especially if you're in your 60s and 70s, prostate cancer is not going to be the thing that gets you if you get diagnosed at that age. You're more likely to die from a heart attack. So that's what I want to leave on. And if you have any questions, people come see me. I will talk to you about it.
Let's talk about heart disease next time.
Okay, thank you.
Definitely, definitely. Revita Medical, go there right now, revitamedical.com, or call 704-847-0011. We've been joined today by Dr. Peter Fotinos.